I don't remember who the speaker was, but the notion was that we as a society, and he studied societies over time. The Roman Empire is the one that I remember the most. He said that societies will expand until they break, where they have exhausted every last resource. And, here we are for medical devices, and we will spend untold millions of dollars and resources and energy to make an incremental change in a device so that it's new. And when everybody does this, and everyone does it until it's no longer viable to do it, we get to the point where societies collapse. And it's hard to envision, like, okay, I just made a switch on my thing, I'm not contributing to society collapsing. But you think about, one more methane or one more carbon or one more, and
kind of summarized by the law of diminishing returns, that we spend more and more to get less and less out of our effort.
And at what point is the less so little? I mean, I don't remember the nuance. I just remember the overall feeling of impending doom and my gratitude for being superannuated and probably dying before the world collapses on itself. And I know my kids will figure out something. But what was that tipping point? What was that like? This is when it really breaks. Do you remember, Nick?
No, but he does. I don't remember like a punchline to it so much as he talks about complex societies. This is a book dating back to the 1980s that's now become popular again, because I think people are seeing it. And it was, societies become complex by solving problems. And he leaves it at that. And you're like, isn't there more to it than that? And Dr. Tainter is his name. Joseph Tainter is just saying, no, that's all there is to it. We solve problems that solves more problems and more problems and more problems. But again, in the law of diminishing returns, there's a point when vacuuming.
Problem you're solving was so like, that.
Yeah, you vacuum your living room carpet one more time, it provides tinier and tinier increments after the 96th time you vacuumed your carpet today. At some point, it's not worth the time, but you can't help it. You have to solve that problem. Are we just going to quit doing breast cancer research, even though mortality has been like this since 1994 and incidence rates have been flat since 1994? But we're not going to stop studying breast cancer, even though we're not moving the needle on it. Tainter is making essentially the same point. The number of authors on the number of patent holders 50 years ago, and it's just diminishing. You now have to have teams upon teams of people to issue a patent, where 50 years ago, you'd have one or two people on a patent. It just takes more and more resources to discover tinier and tinier improvements in nature, society, science, whatever it is.
Can you, if you find that, I'm sure I could find it, but if you have it handy, maybe share it in the chat here. Larry, did you want to say something?
Yeah, I got a suggestion. Think outside the box. What is the molecular cause of cancer? What causes cells to turn into cancer cells? That is an unknown that may still be discovered. And that's where I think we need to keep remembering as knowledge increases and tools increase. I mean, artificial intelligence, where was that 5 years ago? Okay, smart machines, okay? We can't even conceive of what great minds in our world will conceive of over the next few years. Now, I agree, the Earth is ended to an ultimate end, but that could be millions of years from now. And I believe that we as entrepreneurs and scientists need to think outside the box. We know incremental improvements are the easiest. New technologies are the toughest. Yeah. And I wish I could tell you what they are, but I'm working with a couple of companies that have what are called breakthrough devices. They're treating a medical condition that is not treated well at all right now and providing excellent results. The doctors are excited. More importantly for those companies, the big companies are excited because it's a entry into a new form of therapy. And that's, I think, what we can't lose sight of. That's my sermon for the day.
I'm with you, Larry.
We appreciate it. if anyone has anything they want to add on this, but then I think it's a pretty good segue into what Debbie's going to be talking about today, because
I wish I
yeah,
could show you I said, I wish I could show you my presentations on what we've done in cancer. And because we've never published our results in 53 years.
well, this is a very loose, as you can see, forum.
Yeah.
There's no script, and if there's something of particular interest, just go there, and that's fine. Rick, you had something, and then I'll start peeling people off.
Yeah, really. I remember back in the 60s, I would watch a show called The 21st Century, and various futuristic shows, kind of looking at the threats of extinction that we actually faced. We've actually already supposed to have been dead as a world several times over. And it's the innovation of people with with truly hundreds of thousands of people with small things that have pushed it forward. I worked with a guy who developed a cattle to keep a little ear tag to keep entire herds of cattle from being extinct. And I also took a look at the UN numbers on world poverty, and in terms of food poverty. And those things that has virtually collapsed just in half of our lifetimes. They still have a few percent to go, and there's always going to be, if somebody's having some genocidal war, people are going to die because infrastructure will break down. But the world food shortage is now changed to a place where now we're having a world epidemic of obesity and diabetes. And so now we're having to start to, yeah, you're right when you said solving one problem can cause another one. But so many amazing things have happened just in half my lifetime. I'm not saying we should concentrate on those and ignore the troublesome things. I think we should just be holistic and look at it all. And that's what I had to say.
Thank you, Rick, for saying that. And just so, Debbie, you're not the only OUS person here today. Luke, let her hear your funny accent.
I let you hear my funny accent.
Thank you very much. It's time for a pint by him, and it's definitely time for, you look way too nice for 1 o'clock in the morning, Debbie. I appreciate you.
I have actually been sleeping in the day. So I've been working on US and UK time for 2 weeks.
Now tell us why.
I've been speaking in 13 countries. I've been teaching physicians all around the world about our technology for the first time.
Okay, well, introduce yourself. I'll just say that Debbie's been a friend since 2014 when inexplicably, and I still don't remember why, she found out about the 10X conference like with 48 hours to go. Yeah. I was talking with her, I was like, oh, she's nice, but there's no way she's going to buy, I'm thinking like, she's not going to buy a ticket. But she bought a ticket and she came from Australia to Minneapolis when I still had it there. I was like, I'm glad you see the value here. I don't know if I would have done that, but I hope it was worth it for you.
Oh, I was eternally grateful. It was just amazing because what you may not have known is it was only about a year before then that I had given up my 30-year career as an international chief executive to become the protege of my inventor, and which wasn't never my plan. And of course, it was quite overwhelming moving into the medical device health sector from coming out of, executive management. So yeah, it was, I had to quickly try and learn. And then I found your conference and I thought, oh, fantastic. It's only 2 days. Can I get there? Will they let me come? So when you said that I could actually attend, I was so thrilled. And I just couldn't wait to get on the plane, and I had the best time. I still remember all the speakers and what was taught, and it was fantastic. Yeah, so that was my very first training in the medical device industry, actually.
I'm thrilled.
Besides my inventor, of course, but
So tell us about your invention and educate us on what you've been doing.
Sure. Okay, so I met Joshua Shaw. He's the inventor in 2013. And this is his medical device that he created. So it's in 1967, and it got medically registered in 1972. So it has 4 needles around here, and it was originally registered as a therapeutic air ionizer, but it's much more than just an ionizer. So at the time, they didn't know what to call what he created. And his purpose of inventing it was to try and manufacture the smallest molecule of negatively charged oxygen ion that he could.
And I
for-
wonder if your regular background isn't too distracting, could you put that on? Because you're becoming invisible from time to time and it's rather
Oh,
distracting.
yeah, sorry, I will. So I just wanted to put that on first to show you that's what we manufacture. So the aurora lights and the northern lights from above the Arctic Ocean is plasma, and that's what we manufacture in our machines. So that's why I had it on. So just let me turn that off now. So thank you for reminding me.
Sure.
Get to the point. Get to the point, Debbie.
There we are. No, I'm fine with
Better?
rambling is encouraged here. Now I'm just checking out your office.
Yeah. This is where I chill every day. 7 days a week I'm here.
So it started as an ionizer and you create plasma. I'm still in the dark, so keep going.
Yeah. Okay. So we knew that it was very special.
What problem are you solving?
Pretty much we treat the systems of the body. So we are able to treat multiple different biological conditions. At the moment, I've got over 70 clinical case studies in action. We've got 17 medical claims on our medical registration with the TGA. It's all different, from chronic fatigue, where we're also registered for eliminating and preventing viral, bacterial, fungal type pathogens from the body and the blood. We've been registered for that since 1972. So chronic fatigue, depression, we've got multiple claims that we're allowed to make. But what I was really getting at was originally it was registered according to what the knowledge was back in the 1960s. And then it wasn't until 2018 that I was invited by a German company called INP in Greifswald in northern Germany. They're the world leaders of cold air plasma and the largest institute in the world. So I was invited to collaborate with them, and I flew to Germany to find out what it was all about. And they were the ones that taught me what cold air plasma was, and that's what we were generating, and that we've got the world's only cold air plasma medical device that's been used in consumers. So they wanted to know about what are our results in humans. So when I showed them our results.
Right. What was the word before humans? We had the first in
cold air plasma medical
device. Did
device.
You say in consumers?
Yeah, that's been used in consumers. It's been used in humans. So in other words, we have this technology. It was registered as a therapeutic air ionizer. We knew it was more, but there were no words to explain it. And it wasn't until 2018, there was a couple of modifications, of course, done during those years, but it wasn't until 2018 that we finally had a language to explain the phenomena of what this science is. And that was the language of you're producing cold air plasma and quantum physics, and using quantum physics. And it's both absorbed through the respiratory system of the consumer or the patient, or through the skin as a transdermal treatment. So if I told you all the things that it does, you wouldn't believe me.
Well, see, no, that's interesting. Well, first, I definitely have a line of questioning, but you are selling product today.
Yes, we are. Yes.
In the thousands, tens of thousands, millions, what?
No, because I've only just restarted the business since I came back from Wuhan. I was in China. For 2 years, and I was working in the university in Wuhan, actually doing some testing before the epidemic started, and then I moved to the front line. So I was on the front line for all of January and 3 weeks into February. And all I had, by the way, was a paper mask and swimming goggles. That's all I had for PPE, because there was no other PPE for me in that early stage. Plus,
when you say you were on the front line, what does that mean? What were you doing? For whom? Where?
I was treating patients in Hubei province and also up in Hebei province. So I had about 20 machines there, because I was planning on, in the December, I was trying to commence the CFDA, or NMPH it's now called today, approval process for exporting into China. And so that was the plan. However, the outbreak happened, and and I knew that our device is very, very successful in viruses. 97% of my more than 1 million patients in Australia don't get colds and flu anymore. They're protected from them. So I knew that we didn't know it was called COVID-19. Back then, we just thought it was like another SARS virus. And I knew that I would be able to get a result, because I know 100% how it works here in Australia. So the challenge was, how could I do that when I'm I've submitted all my paperwork to the CFDA. I've met with the provincial director of the CFDA. My goal was then to go through the process, but they don't have my science in China. They don't have my technology in China. So they asked me to come and present to a board of medical practitioners, physicians, and scientists and researchers. So I agreed. That was supposed to happen in the late December. And that was about the time really when things started to blow up. So it all got cancelled.
If you'll indulge me, I'm be somewhat linear here because I'm still kind of lost. And I think it's due to the fact that you can do so much that I don't know, I think about, for people who want to drink coffee, this mug holds liquid. I don't know for whom your product delivers what benefit. And if it's, well, it could be so many people and it could be so many benefits, that leaves me completely in the dark with what we're doing. So could you isolate for me the single biggest market that you are approaching right now? Who will buy this technology?
Right now, anybody that anybody that's got respiratory problems or concerned about getting viruses and they don't want to have a virus.
So this is a consumer-facing device.
Yep.
So I could go to, I don't know what Australia's equivalent of Boots or Walgreens is. Whatever. No.
We don't sell our device through. We've got some affiliates and distributors. They're all doctors and physicians.
Okay, so these go in doctors' offices?
No, they can, but normally what happens is the doctor will have a patient who's got a particular problem.
A respiratory problem.
Well, not just respiratory. Since I've come back in March last year, I've had 13 palliative care patients, and 100% of them are in remission now using my technology. But the reason I go there is to try and improve their oxygen intake. So they can actually put this device right next to them without having a mask on, and it improves their oxygen levels. So we get lots of different respiratory benefits.
So what kind of physician would see this patient? Would it be a general practitioner, a pulmonologist?
No, well, the last one I've had is an oncologist, and his patient was only a 25-year-old boy, and he had in my presentation, actually, for another time, I can take you through all this, but he had this 25-year-old boy had glioblastoma and another type of brain cancer. I don't remember what that other tumor was called, but it metastasized through his body, and he ended up having to have quite a lot of his organs surgically cut into, and he also lost half of his lung. So he was sent home. He wasn't expected to live 3 to 4 days at the end. The surgeon called me and asked if I would go and see him to see if I could assist improve his oxygen blood levels, because that might buy him another day or two with his family. So I did go and see him, but I was very disappointed because he didn't respond, and I was with him for half an hour, and normally I can improve someone's oxygen within 30 seconds. But yeah, I wasn't getting a response. So, but then he didn't tell me up front that the gentleman only had half a lung. So I've never treated that kind of condition before. But it took 36 hours. 36 hours later, the surgeon calls me and very excited. He says, guess what? His oxygen levels have gone up. And I said, wow, that's fantastic news. And they were back up to 95 from the low 80s. And so this was great news. And he's still alive today. And he was
is a common theme that people who need to improve their oxygen intake levels should use your device? Is that the main concept? No, for those who have low blood oxygenation?
That's only one of them. See,
again, I'm going to ask you to isolate one for now, because this is so much, and I'm still quite lost, because right now it feels as though you're a one-woman operation talking to doctors. Some guy called you, you went over there, you had a case, but that doesn't sound like a business model to me.
No, I'm not a one-woman operation. So yeah, there's a few of our staff here, but no, it's so what I recently patented our new understanding of the science, and I also patented our biological results in humans, including breast cancer, lung cancer, COVID-19, including wound care, diabetic foot wounds. So, and then also everything that we're medically registered for. So I've gone through and patented all of that just recently. And the main, what my professors have said is to distill everything that it does into 3 words. They said it's called a selective systemic adaptogen. So it's selective in that the reactive oxygen nitrogen species and the pulsed electromagnetic fields and the portals that we create from the machine to the human is able to create a cytotoxic potential against cancer cells and viruses. We have the capacity to also be able to not chemically treat the virus. We're using physics. We're using physics to basically destroy viruses in the upper respiratory system. So the patient uses the device every night as they go to sleep, they turn it on, and every morning when they wake up, they turn it off. So it only takes 5 hours. So within 5 hours, we can clear Streptococcus, Acinetobacter. We're also dealing with bronchiectasis, which is a superbug deep in the lungs for the patient right now, and he's doing quite well. And so all these respiratory conditions we do get results in, but they don't all happen straight away. So when I was in Wuhan, I was having difficulty in treating the patients that were intubated because they're not breathing and they've got the tube down the throat. So the problem that I had was, well, how am I going to fix this? And about a year prior to then, I had a breast cancer case where I've got a woman who I took who was diagnosed with stage 2 lobular invasive carcinoma. And then I started treating this tumor in a special way, a new way. And I started getting results. We were monitoring it every week. I said, if the tumor gets larger, we're going to stop. But if it keeps decreasing, we'll keep going. So she's going, yep, I'm happy with that. So that's what we did. Tumor was decreasing. She had surgery. Tumor was removed. All cancer's gone. So the cancer was gone in the tumor. It was gone in the margins. It was gone in the lymph nodes. So, and that's now, we've got pathological evidence of that after.
Eddie, let me start with you. I see your brow is as furrowed as mine feels, and I'm feeling as though I'm perhaps not the right interviewer this time, that I'm not quite getting it. Are you getting the main point here, or what question would you have to have us?
The way I go about these sorts of situations is I try to understand what is the mechanism of action. Because you showed us a device, you said there were 4 needles on it. I don't know if the needles go into the patient or if they do something, because you keep talking, you were talking about sort of creating, are you creating ozone, or what are you creating with those needles? You say there's physics, I don't know what the physics is.
There's 4 needles here and it can be turned into an 8 needle machine. The needles, there's high voltage inside. The needles stay in the machine. The device sits 1 meter from the patient's pillow when they're sleeping at night, and they turn it on and then they turn it off when they wake up. It's creating a special species off the needles. So we create reactive oxygen, reactive nitrogen species, which is, as you know, can cause, so we have a lot of functionality and mechanisms with the redox system and sterilization.
Now I'm starting to understand. I actually know of some other companies that have created reactive oxygen species in other ways. So that's something I understand. What I've learned from looking at those ones, though, is that basically you have to be very careful because you end up creating some quite dangerous chemicals that, again, a lot of medicine is poison, but used in the right dosage.
Yes. Well,
Nick knows this very well. he's laughing. So,
Nikki, why don't you put on your mic? And Deb, I don't know if you are looking to enter the United States with your device. It's not approved for use in the US.
I have been asked to.
Nikki,
I've been asked to do an EUA in the United States, but so far I'm thinking that it might need to be a 510K. But either way, the FDA in the United States currently doesn't have any cold air plasma medically registered for what this device can do. So it would be like a de novo, to be a brand new type of device.
And I'll bring on Larry to talk about that. But Nick, would you be seeking this device to be reimbursable?
Yeah, that's a good question. And I was equally as confused when Joe was asking, like, how does this work? What is the thing? And Ed asked, what is the mechanism of action?
There's many.
Yeah.
There are many mechanisms of action.
So
In fact, my
Nick's old
professors,
role at Intermountain Health was the guy to decide whether something would get reimbursed or not. And Nikki, I'm thinking right now, from what you've heard, you'd be like, what is this? I don't know what I'm approving.
Yeah, it sounds
Like a too good to be true does everything.
Yeah, it does. It sounds like, I mean, the old phrase, right? Snake oil. It does everything on, and it
Okay.
irradiates everything, and it creates a pulsatile field, you know, and ionizing this. And
Oh, it's more than that. Yeah.
I know,
Pulsed
but that's
electron. Yeah.
what it sounds like. And then if from a reimbursement, health economics, or even market access standpoint, it has to be so much more tight than that, that this device does this, that leads to this, and we've proven it in 50 patients in a randomized prospective trial. And so many companies, I'm not saying yours is like this, Debbie, but so many companies are averse to that and say, I don't want to do an RCT. I know that our thing works. And you go, well, then you stand alone. The way that, whether we like it or not, there's a framework for commercializing new medical technologies that if you operate in it, you'll make millions and you'll cure everything. If you operate outside of it, it looks like quackery. And it looks like what are all these essential oil companies? I live in Utah. It's the headquarters of every essential oil company you've ever heard of. doTERRA right here. The founder of doTERRA lives 2 miles that way. You know, that I keep wanting to ask, like, what are you hiding? Why don't you go do a randomized prospective study with 50 patients over 5 years? Show that you cut ductal carcinoma in situ or glioblastoma multiforme rates by 50%. You cut progression-free survival by half after a month of turning this thing on at nighttime. You increase blood oxygen levels and so on. That I think the message has to be tightened up, because 30 minutes in, I still don't know how the thing works. It sounds like it works in everyone, and nothing works in there. Not even aspirin.
And let me go to Larry, who
Debbie.
Larry used to be with FDA for, I don't know, 2
21
of my lifetimes. And she started saying, I don't know, 510K, de novo. What are you hearing and thinking?
Well, if there's not a similar device, it's a low risk device from the standpoint of the patient. I can see it's not invasive. It's not putting anything into the patient. So it's a low risk device. So it's not an IDE PMA device. It might be an IDE. But anyway, bottom line is Nicholas should work for the FDA because the FDA are doubters. And the reason is that everybody believes in their product, and the FDA says we need evidence. We need evidence. And as Nicholas mentioned, the gold standard is a prospective randomized double-blind trial. Now, what you would do with your device is you would make a device that looks just like yours, but doesn't put out anything. Okay. And then you use your device, you get, say, 50, 100 patients. If it's 100 patients, 50 of them get the real device, the other 50 get the placebo device. Okay.
Yeah. Yeah.
And the doctors don't know, the patients don't know, because you provided the device and they have serial numbers on them, And at the end, if you show a statistically significant improvement in a condition with the use of your device, the de novo process would be the one that you would go through. You would use that data to set. But I'm sure you believe in your device and you understand it intimately. But the rest of us are not. And speaking as from somebody who had to deal with not that you are one, but the PT Barnums of the world, they're out there. The FDA has become very skeptical, and no, that's their job. Their job is to make sure that when a device is offered to the market for treating a certain disease, that the company has got good scientific data, as Nicholas said, to show it. And essential oils, a good example. A lot of mystery around essential oils, and none of them make any specific claims on the labels because that would make them a drug, and they know that. So they
Before you reply, I'd like to kind of wrap up what I've heard the last 3 questions be, and that is, and these conversations are not always one-sided, like we have a presenter and she teaches us something and we're all, smarter for it. It's a very collaborative thing and we help one another. What I'm hearing is, I don't understand, how does it work? And as a marketing strategist and communication person, my hope for you is that coming out of this, and I know you have so much information in your head, we need to, the elevator, like, nice to meet you, so what do you do? I make mugs that hold liquid for people who like to drink. I understand that concept. I understand what a mug is. I understand what liquid is. I understand what drinking is. Got it. You've got lots of conditions. You wouldn't believe how many things. And we're like, okay, so what? So again, I'll ask, if you can, is there any equivalent of my mug example that you may be able to help answer so many of the questions that we're like, we still don't really know what this does.
Well, I've been invited to 13 different countries over the last 2 weeks. I'm recognized as the world's leader in cold air plasma. And it's very difficult for me to talk about it without going through my presentation to teach you the science first. Cold air plasma is not something you're probably familiar with yet.
No.
But there is an industry. There's about 130 professors full-time around the world studying it. In fact, the FDA has just approved, I think it's George Washington University, to do the first clinical trial using a cold air plasma on sterilization of wounds and burns in, I think it's George Washington University in America. So, and I only know about that because I was invited to speak at the Plasma Sciences Conference 2 weeks ago, which was over 5 days in South Korea. And so I got to hear, what's actually happening all around the world in the different labs. But the majority of the world is still, the gases that they put into their devices, they use nitrogen and argon, and they man-make gases. We just use ambient air, so it's quite a bit different. But we still use the same pulsed electromagnetic fields. I'm still creating dark energy inside the human body from a biological perspective to get a result. I'm still providing, it is complex science to understand it. We also use water memories to be able to transport that energy and hold it in the blood system for up to 20 hours a day. So all the patient has to do, and really what I'm focused on right now is just COVID. So, the patient can just use the device on their bedside table, and it clears the upper respiratory system for them every night as they sleep. So if they've picked up some bug or, a virus is starting to take hold in the upper respiratory before it travels to the lungs, it's going to actually have the ability to selectively destroy the virus. So it can kill the bacteria in the upper respiratory system, but it protects the good cells at the same time. And then on top of that, it has an immunogenicity memory. So the immune system can remember what it's done. So the more you use it every night, the better protection that you have, which is why 97% of my 1 million patients in Australia since 1967 don't get colds and flu anymore. So, and the way we kill a virus has got nothing to do with how you currently think a virus needs to be killed. The entire industry in the world thinks that a virus has to be killed by, well, I'm using my language, excuse me, but the virus has to be eliminated by as treating the ACE2 receptor on the epithelial cells and lots of other type of chemical ways. Well, we don't do that. So what happens is our species, when it comes out, the air species is really, really small. So oxygen is 0.00012. A virus is 0.012. Well, my species is 0.1700564. It's really, 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 really small. But also CERN and my professors have the evidence, it's now in the papers, it's now been publicly published, that the species can spin at a rate of 1700 degrees Celsius. But you don't feel it, you don't know it's that hot because it's atomic. We're talking about the unseen world. So there's a reality in the seen world and there's a reality in the unseen world. And we just happen to have put the two together 53 years ago, but we didn't know what to call it. So this device was way ahead of science and the medical fraternity. And only now the scientists around the world since 2018 are now recognizing it. So if you go to my website, bionicair.com.au, you will see what the professors have actually said there. So they're amazed.
I'd like to interject. I'm really glad I pushed, because what you just shared in the last 3 to 5 minutes is better than anything that resonated with me from the 40 minutes before. Because let me tell you what I'm a very simple person. I just know, like, Larry is the FDA guy and Nick is the reimbursement guy. That's all I can retain. When you said I am one of or the foremost expert in cold air plasma medicine, that was something, okay, I don't understand what that concept is, but you're the gal for it. And then I thought, what is the benchmark? Well, the other technologies that are presently being used, which I don't know what they are, but they're A, B, C, D, and E. This is F. This should be in the consideration set with how we're typically doing things. And I would say right now, your device aside, when you are talking about solving these conditions and you're considering these other known things, consider this one too, invite Debbie and she'll have you think about that so that perhaps your technology is going to be part of a bigger solution and people will want to work with you to understand how that can work. There were a
Yes.
lot of pronouns in there that I don't really get, but at least I have a framework now of
Mm.
what your value proposition is, not your device, what you bring. And you have a device that does stuff, but I kind of get that. Would you gentlemen agree? No.
Yeah, I was invited by the United Nations to speak in Italy last week. And the week prior to that, I was invited by a group of physicians in the UK to sit on the emergency COVID-19 solutions committee. And and since then I've been, speaking in Malaysia and South Africa and France and pretty much living on your side of the clock, not mine, sleeping during the day. So that, thank goodness I've got a great team around me, so I don't need to be involved in the day-to-day running of a business. But so yeah, it has been really good. It's been very eye-opening for many doctors. They've never seen this before, but they sort of need to go through my presentation where I can present what the science is first, to give them an understanding and teach it to them first. And then I talk about, now here's the results we've achieved in humans. And that's what they then need to go away and have a really good think about it, because it's a lot of information to take on and they're quite overwhelmed. Yeah, but then we've got machines everywhere and they're getting the same result as what I know they would. So, in Wuhan, that's the other thing I was going to say to you is, when a patient's intubated, we treat the patient through the back. So we put them onto their side and put their body into the fetal position. And I would treat the base of the lungs through the skin, facing the machine about this far from the bottom of the rib cage. And each of those 3 patients that were intubated were able to recover enough to be able to have the intubation removed and then to be able to be discharged from the hospital.
So 2 quick questions. And if you get this one last, what is there something that, and I've got a very personal reason for this, is there something that this device can do for people with acute asthma? But the other thing is that the explanation that you just got done before Joe told you what a great explanation it was a fantastic way to start this, because it begins the narrative with, this could happen, like seeing a bunch of superheroes appear out of the sky, and you're going like, and they're saving everybody, and you're going like, man, this is great. How do we get these superheroes to show up? This really is quite amazing. We were talking about world-changing type stuff, which if made workable, could actually change the way things are done, not just incrementally improve them. And
I already know
I'm
it
just,
does. Yeah,
yeah.
I'm 100% convinced. I've given up my career for this technology. I've sold my children's inheritance and homes and properties to support the company to get this business up and running. Unfortunately, I'm really, really honored to have spent 8 years with my inventor before he passed away. So I was his protege, and I spent a lot of time learning what he taught me. But also, I've traveled the world after finding out what the science really is. I traveled the world to every single university to meet with every professor that would have me, and to collaborate and learn as much as we could. So yeah, it is really, really good. We've got a lot of scientific evidence already. We've already done some trials. I've got 72 clinical case studies underway right now. And, one of, I won't go into what they are, but so my academics will, when they're satisfied with the the evidence that we've got for that, then they will start publishing papers. But we've never published our results in 53 years. So our first paper is due to come out in about 3 to 4 months' time. And that will be probably, I've been told it'll be, well, they're tossing up. They're either going to deal with the breast cancer case, or they're going to deal with a meta-analysis on what we've done over the past. So I don't know which one they'll do. It's not my area of expertise. So,
You say that you haven't published anything yet.
no, never.
So Larry, that's got to be like, I'm even seeing you make that brownie face.
Well, what she's describing is a rather unusual history of product development from my perspective, that still needs the strong controlled science behind it, and not having published anything, to me, is a red flag.
Yeah, we didn't publish anything because we couldn't explain the science, and
But
quite
you feel
frankly,
you can now.
Well, you know,
Yeah, well, also Josh, our inventor, he spent $5 million in legal cases trying to keep the product on the market because he was a threat to too many companies trying to close him down. So with exactly what Rick was just talking about in relation to asthma, some big companies were trying to close us down because we did do a clinical study, and that clinical study showed, which is in my presentation, it showed the clinical trial showed a spore precipitation and an immune system reactivity for allergy and asthma of probability of 0.001, so statistically significant. But then we buried the whole thing because of the problems that the company that was threatened by it was causing for Joshua. And Joshua pretty much went underground after that. So he pretty much just kept his technology in Australia. He never really advertised. He never needed to. So it was just organic growth in the company for a long, long time.
Eddie, you wrote me some comments that you have familiarity in the space a bit.
Yeah, there's two guys I know in the U.S. who have, from what you're describing, it sounds very, very similar. Theirs is, again, it uses electricity to generate reactive oxygen species. And where they're positioned, again, going back to what Joe was saying, is a clearer business model, which says, in hospital environments or in other closed spaces where there's the possibility of infection risk, especially if things are ambient in the air, circulating a reactive oxygen species, like I say, what this does is, as it was described to me, is fundamentally, if you're creating reactive oxygen, oxygenation is a very, very damaging process to lots of things, not just viruses and bacteria.
Yeah, it does.
And so your claim, so your claim that it's completely harmless to human cells, I need to understand why. I go back to that mechanism of action issue. But fundamentally, that I can understand where you're coming from, but physics is physics. And I was also very confused by your statement that your oxygen is loads smaller than normal oxygen. That just doesn't make any sense. Do
you know about the oxygen singlet?
The oxygen, what you mean, a single oxygen molecule?
The oxygen singlet.
Or a single oxygen atom, because the oxygen atom really is unbelievably reactive, and it can't sit on its own. It goes, you go back to your periodic table, it has to run into something and form some other chemical reaction.
Okay, but what if I could prove to you that what we used to know is actually not actually accurate? Because
what, the size of an oxygen molecule isn't the size of an oxygen molecule?
No, it's just the type of oxygen we produce is not the oxygen you can breathe when you're out on the Earth. You have to go 200 kilometers above the North Arctic Ocean to breathe it through the plasma. So we already know what we're creating, and we also know the mechanisms in the body. A lot of the research has already been done and published in relation to that already in cold air plasma. So the redox, what we do with the redox system, it's a selective systemic adaptogen. So it has the ability to not only just kill, as you know, it can cause apoptosis in the cells, it can damage cells, but it also creates a complementary reaction that actually protects the good parts of the cells. So, apoptosis and killing of cells is something our bodies do every single day. So the redox system is actually something that our bodies are constantly generating. But there's lots and lots.
But like I say, it's about concentration levels and where those reactions are happening. Yeah. In the same way, you can have good bacteria, but if that good bacteria ends up in the wrong place, it can become bad bacteria and cause infections and kill you, right?
My academics are better at explaining all that than I am. They understand the science side better than I do.
Andre wrote me and said that he's working with a client now that's working on something that uses electronic plasma. Would you talk to us about that, Andre?
Yeah,
Thanks,
sure,
Eddie.
Debbie. Debbie, I've been fascinated. Hi, I've been fascinated what you're talking about, because we've been on a project now for 2 years and helped develop a device for a client that uses high voltage electric plasma to take the ambient air, nitrogen, the oxygen in the air, and combine it together to make nitric oxide, high flow nitric oxide. And that's gone through now the first dose ranging study in accordance with FDA and FDA IDE for treating diabetic foot ulcers, which was, worked out successfully. And the next step now is actually an RCT for the pivotal study to go to the FDA, because we're actually in the process of a PMA. So, we're going through a long process, but really it started with the application at the FDA, showing how the development of plasma generated nitric oxide could treat diabetic foot ulcers. Dose ranging study was successful. We have the dose range, and now we're into the process of getting ready for the RCT for the pivotal study. But that went under a PMA at the FDA, which, takes some time. And as you said, there's nothing out there directly that could be substantial equivalents for a 510K. So that's the route that it took. And I'm just wondering, are you in that role of, you've said these studies, for example, when you talked about the asthma study, that seemed very interesting. Was that a controlled study against a placebo device?
Yes, it was, but it was done back in the early 1980s.
I see.
And like a lot of our work, it was hidden because the results were too controversial to too many companies. However, the science industry has now caught up with this technology, and we're getting very, very different. You'll find if you have a look at INP and Griesfeld in northern Germany, they've actually just released some fantastic work on what they've done with diabetic foot ulcers. So in fact, they've moved a part of the plasma laboratory into the diabetic hospital. And I've actually been there, and I've met with their hospital, and they've got one of my machines up there too, actually. So, but I don't know if your client's doing the same, but they're using the traditional cold air plasma, which is the shape of a pen, and the pulsed electromagnetic field is inside the barrel. And their plasma can only emit about this sort of distance, about an inch from their needle, and it can't go any further than that. So it's used by surgeons and doctors directly into the wound or into the cancer, or
the one that we're making. It's recessed within an applicator, and then it's just really the nitric oxide that's coming out. But one of the other points that I was just going to ask you about is that I think people were mentioning before, this company decided to focus specifically on the diabetic foot ulcer, although they believe it has many other applications. But for FDA purposes, I think you heard before Nick talked about the fact about focusing on one area. And that's why they decided to focus specifically on DFUs, although it has many other applications, but first getting through the FDA with one specific application. So of anything from this call, I think that's probably the most important thing, is to, pick out your best candidate and just go after that if you're looking at the US FDA market.
We could look at one candidate, but the results people will get will be much, much greater than that. But I'm always happy to underpromise and overdeliver. We have to do that in our market. Here our tagline is breathe better, sleep better, be better, and that's it. And so that's all we're allowed to say really to consumers, to keep it under promise and over deliver. But the results we
get, you are selling it for nearly $2,000. How many units have you sold? Is that something you're willing to share?
Just over 1 million.
You've sold 1 million units.
Yeah, since 1967. Yeah, so quite a lot of units we've sold. But what happens is now the TGA has put in place this new rule that we have to do post-market analysis, and it's fantastic that they've done that, because under post-market analysis we now have to monitor the patient after taking delivery of the device. And so now we're able to start recording so many more results that we weren't able to do before. And that has all led on to the 72 clinical case studies we've got on the go right now. So my registered nurse who works full-time for me, she's full-time just focused on ensuring compliance and dealing with the patients every day, because I'm the one that actually does the diagnosis on how to use the device according to whatever their symptoms are, or whatever the doctors referred it to us for, because there are a whole range of different medical illnesses, not just sleeping and breathing better.
Nikki,
you raised your hand once she said she sold 1 million units.
Yeah, and I'm curious if that's what's funding the company. How are you financed, and are you allowed to talk about the average sale price of this?
Oh, they sell for 1,995 Australian, so that's about 1,500 US, I think. Is that right, Joe? About 1,500 US, I think, at the moment.
I don't do that in my head, but let's go with that.
I should say, yeah. We sell probably about 5 a month in the US. Because in the US they don't consider it a medical device because it has a label on it called a therapeutic air ionizer. So they consider it to be an air purifier. However, Customs does know that in Australia it's a medical device, so they have asked us questions about it. But because the registration happened in 1972, it happened before your new customs law in the late 1970s. So it can quite freely go into the US right now, but only one machine at a time, just like one-offs.
I brought Lee on because as I
Hi,
think
Lee.
about the members of the group, he's, in my mind, the biggest thinking entrepreneur with great access to titans of industry. And is that overselling you, Lee? Maybe a little. You're on mute. What did you hear this last hour, and what counsel, of any, would you give Debbie?
I liked the way Debbie wanted to approach it originally, which was to share the science. She said that she likes to explain by sharing the science from the beginning, and I'm not sure that I understand the science.
So Joe fucked it up, is what you're saying.
No, we talked about a lot of concepts, but I think as I read the chat section, I think many of us shared like trying whether the molecule's bigger or smaller. We just didn't really understand the science. But I was thinking about buying one anyway. And
Look at that. You made a sale, and I get 50% of anything that gets sold on one of these things. So this has been a great day for everyone. He's going to have better health. You've made a sale, and I've made some money. This is great.
Mm.
All I got was a
because I would like to see it in a lab. There's no reason. It's non-invasive. It's not hard to test.
That's right.
So,
That's right.
but I do remember when I was growing up, my parents actually had an air ionizer in our house. So I don't know why they had it, but I remember playing with it frequently when I was a kid. By putting
You might have even had my device there, because when Joshua, we've actually got a 510K certificate, but Joshua was distributing product into America through a guy in Chicago, and I went to meet him, actually, Joe, after I first met you, and he's probably had about maybe 1 or 2 container loads of devices over the years. So he's had a lot of devices in the US, and then all of a sudden, Josh found out the 510K he had was fraudulent, and the CRO company he paid took his money and didn't actually. And I've still got a copy of it here. I still got the FDA stamp on it and everything.
Nice.
So yeah. So then Josh had to pull out of the US, and that was in the 90s, I think it was, mid-90s.
Well, I know that this.
I can't figure out what I would be measuring in me. If I bought one, and if I wanted to do an N of 1 non-IRB anecdotal study, like if I put it there, like what do I measure? Even if I have the ability to do my blood with mass spec, like, it's very interesting because we're looking at a technology now that has reduced mass spec from 2 hours to do a blood sample down to 40 seconds to do a blood sample. So, I very easily could take this and test blood every single day against 22,000 different markers. And that would be really interesting. And I have that technology available to me. So I'd be curious as to, it's not one of these things when you do a breast cancer test, there's a lot of variables and a lot of moving parts, but just seeing what it does to the blood might be super interesting.
Well, we've already done tests on Streptococcus, Acinetobacter, upper respiratory, nasal and throat pathogens. We've done that at a university. We've done brain frequency tests to make sure that the frequencies that we know from experience is actually matching what science now says. That was done in 1992 in Japan. And in the blood, we've been testing serotonin, melatonin, and phagocytes. We know it excites the phagocytes. We know that serotonin falls at night and melatonin increases, so that's another mechanism of action that's present during the evening. But a lot of those you'll see in our paper then when it comes out, because we've got it all patented now. So yeah, I don't think it'll be an issue for our academics to start putting it in writing.
Thank you, Lee. Debbie, I'm sure with some degree of confidence that this hour was unlike the hours that you have or will spend with people from 13 other countries, because this was very interactive and we bombarded you with questions and you never got a chance to even give your presentation, which I hope didn't frustrate you too terribly. But I do hope that the nature of the questions that we asked will prove helpful for you in terms of when you're talking to the rest of us who don't understand cold air, plasma medicine, and the like, that there's some kind of language that can help us grasp faster so that you can get that out of the way and we're like, okay, now we're ready, go, you know, and we, my fault, probably, I apologize. But
it is actually difficult concepts to get your head around. And even with my professors, you know, I can't, none of them have been able to. I've got one slide that can show you.
Can you show us now?
Sure, I've got one slide that shows you what our technology is, which one of my professors helped me put together. And I think I just got to share my screen, don't I?
Yeah. There on the bottom?
Yep. And water memory. So, okay. Can you see the screen?
I cannot presently, no.
Okay, so share.
Yes, now I can. Thank you.
Okay, so you can see that's how it sits next to the bed.
Yes.
Is that what you're looking at, this screen?
Yes,
or?
yes, thank you.
Okay, great. Okay, good.
And for you folks, there's her contact information if you want to follow up with her, or Lee, if you want to get yourself one.
So it works in the respiratory and transdermal through the skin. It produces ROS and RONS species, plus lots of other quantum species, which I'll explain in a moment. The species we produce, we only do on a negative and neutral polarity, so we don't produce anything with a positive polarity. We use pulsed electromagnetic fields and ionic winds, and we create our own quantum physics novel portals, which is a special way we transport the species and the fields into the human body. Then we create Ruach life force, which is like a dark energy inside the human body when we generate photons of light. And that's what helps to create the water memory and the energy that helps to stay along the fluids and around the blood system and the intercellular fluids around the entire body. And the other things that impact the species is the blood pH, the salts, the currents of the blood and the water in the body, the water bubbles inside the body, and the ability for the immune system to hold its memory. And that is all we can control these by controlling the vibration and the spin, the resonance, the frequency of the species itself. So we have selectable outputs, we have selectable frequencies, and and then we have a sound that's not audible to the human body, but we can make it audible if I need to try and match it to a virus. That's how I came up with the right settings for COVID-19.
I had to bring Nick back on because you used the word polarity, which was the name of a company that he was vital in. Nikki, what can you tell us about that? And what did she just show that resonated with you?
So our term for polarity was the way tissue grows, you know, in a hierarchical structure, epidermis, dermis, hypodermis, and so on. So our definition of polarity was a little unique, different from Debbie's. But you know, with this slide, I can give my academic record as well as anybody. I mean, my master's degree is in biomedical imaging, which is in other universities called biophysics. Boston University School of Medicine. And I don't know 9/10 of what you just showed on that slide. I mean, it just sounds like so much and so many acronyms and terms and dark energy and life force and all these things that I mean, most of the data that's been cited is 30 years old. You know, I don't know why your company can't do a randomized, prospective, multi-centered, sham-controlled study on one single solitary thing, understand the mechanism of action of that one single solitary thing. So anyway,
we can do that. We can do that.
But why hasn't it been done since 1960? And this Jeremy fellow is the worst luck individual I've ever heard in my life. I mean, a fraudulent 510K certificate, which doesn't exist. There's not a certificate. I mean,
I've still got it. I got it here.
You had to go underground. I mean, these terms are things that we hear on Friday night TV in the United States about some company that is. Debbie, I'm a little gobsmacked at this discussion. I'm glad you came on, but I don't even know where to begin from a reimbursement health economic standpoint. I hear of 40 years of research creating ionizing this and that, and plasma and all of these things. And I have a master's degree in biophysics. And I'm listening to this going, I don't even know how to have a discussion about this.
You know, Nick,
I hope it does amazing things. I'm sure there's some anecdotes, but I just don't know where to begin. And I don't know that you're asking me to begin.
No, and since I have to say, for the last 6-7 years, every time I've gone into detail of studying so many different fields of science and medicine, I've been writing them down. And I've now studied 38 different multidisciplinary areas of science and medicine in order to really get my head around how the technology works. And I put it into writing, and it became a 200-page book with 140 references and 200,000 case studies.
So that's published.
No. I'm never publishing that. I'm not a writer. I just wrote down everything I was learning for my own sake. You know, I could never publish that. I'm not a medical writer, but certainly I'm going to give that to my academics, and no doubt they will write it all up in some sort of easier ways for people to understand. I understand it, but you know, it's just my language.
Right. Okay. Thanks, Nikki. Well, this one was a little unusual for me, because by the time we conclude, I typically have a pretty good handle on, and I can't say I do today. So I don't know a logical way to conclude today's call. What would you say, Deb? What, if anything, did you get out of today's call?
For myself? Yeah, I mean, it was nice to catch up with you, Joe. And I do appreciate everyone's feedback, and I was half expecting it to be like it is. I know the frustrations of having a working device that's so mature, and
the fact that you sold 1 million of these is astonishing to me.
Yeah, I know. Every single device we sell, and by the way, my advertising budget is about $1,000 a year. It's nothing. So every machine, we sell one machine, and that person gets such good results, we sell another 9 of that. So we already know what our referral rates are. They're stronger than Nike shoes. So, but you know, we've had a lot of difficulties. Josh retired, and then when he passed away, I had to settle up his estate. So we had to close the business for 12 months.
Do you have any investors? I know you've put a lot in.
Yeah, I have put a lot in, and I'm currently talking to investors right now
But right now it's you and friends and family?
No. I've got a team of 12 people here.
Pardon me, I mean the money.
The money's all mine. It's all mine. It's all my investment. Yeah, I've been paying for it all. I've sold my homes. I've sold my investment properties. I've been supporting the company for 8 years.
Wow.
And but it hasn't always needed my support. You know, we have we have passive revenues every month because people get results, and you know, then their friends get sick and they refer it to their friends, and so, or doctors refer to us. So, you know, we don't really need to advertise. We've been organic growth for a long time, but if we did advertise, it would really take off. But then how do you advertise a device like this? How do we communicate it? We're struggling with that. We don't know how to communicate it.
Right.
And then on the science side, you know, we've wanted to write papers and wanted to do science, you know, in the last 7 or 8 years, but how could we do that when nobody understood it? So it's only just happened since 2018 that we actually found out what today's science actually calls this technology. And it's, you know, and it is quite complicated to get your head around. So there's got to be easier ways of doing it. But we've got a really good professor team now. So I'm really happy with our advisory board. And, you know, we're now looking to physicians in the US and in the UK. We can't do a clinical trial here on COVID-19. There's not enough patients. And plus, you know, with the lockdowns, we can't even get the devices there. It's easier for me to send to the UK and the US than it is to Sydney. It's crazy. So, yeah, but so I'm looking, and then I'm looking for a manufacturer in the US, and then I'm looking for a distributor in the US. So I've been contacted by 2 lawyers that have had something to do with the FDA, and they're the ones that have asked us to do an emergency use authorization, and they've sent us some paperwork to complete.
Well, I'm glad that Andre joined the call then, because he might be someone who could help you manufacture. He does contract manufacturing, and given that he has some experience in a similar product, maybe there's a match, and I'll be sure to put the 2 of you together. So
Yeah.
You found someone who might make some stuff for you, and you got a customer in Lee. I'd say this is
Yeah.
really good.
And two of my professors are in the US as well. So, you know, and they're doing some fantastic plasma work. But they use very high voltage plasma, and their plasma can't be used by a consumer. It's got to be used by a surgeon or a doctor. And because it's man-made mixes of gases, and it's also very high frequency, and yeah, and they put it into like a pen. So in the surgery, they'll actually use it into the wound, so they don't need to dissect so much.
Well, I know it's now 2:15 in the morning for you, Saturday morning. I'll conclude today's call with my great thanks. It's really good to catch up with you. And I think that this was a good example of how the network works, where Larry had something to say about FDA, and Nick had something to say about reimbursement, and Andre about manufacturing. And that's kind of how we all help one another. So thank you.
Yeah, that's great. No, I appreciate it.
Now go to sleep.
Oh, no, I've got a few more hours to do. Yeah, no, I've got some work to do in South Africa actually tonight. Yeah.
Oh, okay. Well, I'm going to take a nap anyhow. Thank you, Debbie.
Right.
Be
Thanks,
well.
Jane. Okay,
Bye.
bye-bye.
Bye, everyone.